Welcome, everyone, to another Matters of Vision program. My name is Dustin, and I'm the Communications Director for the Macular Degeneration Association. We are a 501c3 nonprofit supported by donations from people just like you. The Macular Degeneration Association was founded with the mission of ending this eye disease that has quickly become the #1 cause of blindness in adults. We are always on the search for new research to fund, for providing education for the newly and not so newly diagnosed, as well as providing hope for the future. If you find today's information helpful, please help support our work by making a donation. Today's program was also made possible by our sponsors Regeneron, Apellis, Novartis, Alexion, and Notal Vision. We would like to thank them for their continued support of our programs like this. Today's program is titled Eyecare Open Forum, discussion on glaucoma, cataracts, diabetes, and AMD. You will have the pleasure of hearing from a wonderful speaker who is the Macular Degeneration Association's Optometry Medical Director, Dr. Jeffrey Gerson. He has published multiple articles in scholarly journals and is experienced in cutting-edge diagnostic technologies and clinical trials. His expertise and knowledge have earned him the title of the Kansas Optometric Association's Young OD of the Year. Dr. Gerson practices at Grin Eyecare in Leawood and Olathe, Kansas. Dr. Gerson, the floor is yours.
Well, thank you, Dusty. I appreciate the introduction. And I'm going to go right into what we're going to be talking about today. First of all, I just want to thank everyone for coming on and joining us today. I also want to make sure that everybody knows that part of the function through this webinar is there's a Q&A section. And although I do have some slides prepared, the majority of what I was hoping we'd do is ask and answer questions. So if you go to the Q&A section on the drop-down toolbar that you have there, you will be able to send in any questions that you have, and I'll try to either answer them as we're going along or at the end once I've finished presenting what I'll be presenting to you today. So again, as you think of questions, go ahead and type them in and we'll get those answered for you. As Dusty said, my name is Jeff Gerson and I'm an optometrist in Kansas City and get to be the Optometric Medical Director for the Macular Degeneration Association. So again, this talk is really meant to be interactive with questions from you. I've prepared some material that I think is interesting and potentially valuable, but what's most important is that any questions that you have are actually answered. And it can be on the topics that we're presenting today or in any other eye care topic. I promise not to bore you with a bunch of sciencey statistics, but hopefully instead we'll be able to give practical answers to your questions. And just to let you know that I do speak from a position of real world experience, that I see patients every day and I see patients with the conditions that I'll be talking about on a virtually daily basis. So this is something that is very common in eye care. And so, you know, most of the questions that you would come up with are probably things that I'm already answering on a virtually daily basis. And so there's no such thing as a bad or dumb question. I guess the only dumb question is the one that's not asked at all. So please, again, feel free to send in any questions you have. I wanted to start with something that's fairly hot off the press and something that we get asked about whenever we do these forums. And as it turns out, it's already been posted to the Macular Degeneration Association's website, blog, Facebook, and our other social media outlets. Oftentimes we get asked about stem cells for treating macular degeneration. And as it turns out, just within the last week or so, the first patient to receive a stem cell treatment for dry macular degeneration just happened. And this is in part of a phase 1, which means very early phase trial by the National Eye Institute. The goal of the National Eye Institute for this study is to enroll 20 patients, and patients will then be followed for 5 years to see, first of all, not if it works, but if it's safe. But secondarily, if this treatment helps to prevent the progression of dry macular degeneration. Most of the things that you hear about as far as treatments for macular degeneration are for wet macular degeneration. However, far more people have dry macular degeneration than the wet kind. So this is something that could be potentially pertinent to millions and millions of Americans, and maybe many of you. Now, before you get too excited, I want to point out that the proposed completion of this study is in 2029. And this is a very early stage study, very early stage trial. So bottom line is we're still more than 10 years away from stem cell therapy being something that is approved and available for macular degeneration. So the good news is there's science. There's now a National Eye Institute clinical trial. The bad news is we're still looking at likely another decade or more until this is something that becomes a reality for us in everyday clinical practice. But hot off the press, wanted to share this with you. If you have more questions, you can go to our website, look at the blog, and we have a little bit more information for you there. All right, so first question that I wanted to answer, no one asked this yet, but I wanted to answer, is what's the difference between an optometrist, an ophthalmologist, and a retina specialist? Because some of you may see one of these, or two, or possibly all three. Because some people will say, well, do I need one of each? So an optometrist is what I am. So I went to undergraduate and then 4 years of optometry school, and then did a 1-year residency and take care of people's eye issues and do everything from fitting people for glasses to contacts, treating red eye, glaucoma, basically anything that does not involve a surgery or an injection. An ophthalmologist is someone that after undergraduate went to 4 years of medical school, then did a 4-year ophthalmology residency. And so the biggest difference in what an ophthalmologist and an optometrist does is ophthalmologists do injections and surgeries. And so the most common surgery that an ophthalmologist does is cataract surgery. Then a retina specialist is someone that's an ophthalmologist that then received 2 more years of further training to deal only with, or specifically with, problems with the retina. So they are an ophthalmologist, but deal directly with retina. So actually we've had our first question come in. The first question is it possible to sign up for future tests for dry macular degeneration? So what I assume you're referring to is clinical trials. And there's a website that you can go to. It's clinicaltrials.gov. So just the word clinical, CLINICAL, trials.gov. And then it will give you some fields to fill in. And so you can look up studies on or clinical trials on macular degeneration. So you can put in macular degeneration for the condition, clinical trials that are recruiting, and you can put in your specific region or location, and it will find if there are any near you. On the last one of these virtual talks we did, I put up some numbers that there's somewhere around 1,000 clinical trials going on right now in macular degeneration. So there are many, many, many. And so it may be that one pertains to you, depending on your condition, maybe not. Okay, so I already talked a little bit about optometrist, ophthalmologist, retina specialist, and some people do indeed have all three. Because if I have a patient that develops wet macular degeneration, I'll send them to a retina specialist. If they then develop a cataract, then they'll see a general ophthalmologist for their cataract surgery. And then after they have their cataract surgery, they'll come back and see me to see whether they need glasses and figure out the correct prescription for that. So it is very possible that somebody sees all three. It is quite common for people, if they're seeing a retina specialist, to also be seeing either an ophthalmologist or an optometrist, taking care of their general eye care needs. So none of these three really does everything that somebody will need on an ongoing basis. All right, so let's go to the next slide. All right, so again, what I'm going to do is for the 4 main conditions that were listed, I'm not going to do a top 5. I think that's not kind of the way I want to approach it. Instead, I want to give you 5 things that I want you to know about each of these common conditions, because again, they are all very common, and just want to share some information on each of them. Now, what didn't make the original list or the title of the 4 conditions that I want to address up front is something called astigmatism. And it's kind of a joke amongst optometrists, the way people say astigmatism, because patients don't know how it's spelled or to say it right. So they call it the stigmas or stigmatisms. But astigmatism just means it's another name for needing glasses. Everybody's heard of nearsighted or farsighted and thinks nothing of it. Excuse me. And astigmatism is just another type of prescription. It's not an eye disease, does not require surgery. It's another type of prescription. So the way I describe it to patients is, if you've heard of nearsighted and farsighted, they're basically the same as astigmatism, just a little bit different in how we correct it to help fix your vision. So astigmatism is not something that you need to worry about. So we're getting some questions coming in, which is great. So I'm going to go ahead and address some of the questions coming in. So one is, I have cataracts that need to be removed, but I also have wet macular degeneration. Can I have them removed? Will my vision improve? So I guess kind of a two-part question. So can you have the cataracts taken care of through cataract surgery? Yes, absolutely. Will it improve my vision? Most likely, but with tempered expectations. And so the way that I would describe this to somebody is that, think of your eyes being like a camera. And by the way, this analogy doesn't work with people younger than maybe 30 at this point, and you'll understand why in just a moment. Think of your eyes as being like a camera, and your retina or macula, if you have macular degeneration, that affects the film in your camera. Now you understand why people younger than 30 don't understand this. They don't understand that cameras ever had film, or cameras were ever anything other than your phone. But if you have macular degeneration, it affects the film in the camera. If you have cataracts, that's like having one of the lenses within the camera being foggy. And so they're not related. So if you remove the foggy lens, will that help you to get a better picture? Yes, it will, but it doesn't compensate for the issues that are created by the problem with the film, with the macular degeneration. So people with macular degeneration certainly can have cataract surgery, and if they need it, they absolutely should have it, but with tempered or realistic expectations as to what the result might be. All right. So a couple other pre-notes. And so what I would tell you is, there's never been a better time to need healthcare, including eye care, or in my case, to be providing it, because treatments continue to take giant leaps forward. So that clinical trial that I mentioned to you about stem cells, that's been in the making for many years. And so for it to finally be starting is really a big deal, and hopefully will lead to some major advances. An ongoing theme of the conditions I'll be talking about, or really any eye condition for that matter, is the importance of early diagnosis and ongoing care. And I would encourage you to take advantage of online education opportunities. So once a doctor tells you about something, they probably don't spend a whole lot of time describing it to you, but hopefully give you some resources and places you can go, whether it's, paper or somewhere to go online to help educate yourselves. And so again, kind of another plug for Macular Degeneration Association, macularhope.org has some really good education, specifically on macular degeneration, but also on other conditions as well. All right, so we're going to start with glaucoma. All right, so again, so I'm going to have 5 points or topics for each of these conditions. So number one, glaucoma rarely causes pain. So you won't know if you have glaucoma or high eye pressure. There are some exceptions to this rule, but in general, somebody with high eye pressure or glaucoma will not know that they have it. So it's not something that you can say, well, I don't have glaucoma, my eyes feel fine, or I don't have glaucoma, I don't feel any pressure. That doesn't mean anything. Nor does it mean something to say, well, gosh, I feel like I have pressure behind my eyes. It's probably not glaucoma. So glaucoma is generally a condition with no symptoms in the early or even fairly moderate stages until it becomes pretty severe. So the important thing is routine eye care to catch glaucoma early when and if you ever develop it. Not all patients with glaucoma have high eye pressure, and not all people with high eye pressure have glaucoma. So if you've had your eyes examined, you know that one of the standard things that gets done is to check your eye pressure. And it's normally a number usually between 12 and 20 or 21. And some people have in their mind, kind of a magic number that if their eye pressure is above a certain number, they have glaucoma. And that's certainly not necessarily true. There are other things that go along with making a diagnosis of glaucoma. So you can have high eye pressure and not have glaucoma. Conversely, you can have low eye pressure and still have glaucoma. So It's not just one measurement that determines whether you have glaucoma or not. Most people with glaucoma use eye drops as their form of treatment. However, some do not. Some people actually have surgery or have a laser procedure done to help treat their glaucoma. So there's not just any one treatment, fix, cure, whatever you want to call it, for glaucoma. There's a whole toolbox of different treatments that could be used, and it's oftentimes a little bit different for every person. If someone's using drops, they may be on one drop once a day. They may be on as many as 3 or could be 4 different bottles of eye drops each day. So the way glaucoma is treated depends on its severity and response to treatment. Glaucoma is more common in African Americans than it is in Hispanics, than it is in Caucasians. It doesn't mean that if you're Caucasian, you will not get glaucoma. It does not mean if you're African American that you will. It just means it helps you kind of stratify or look at your personal risk. Again, the only way to know whether you have glaucoma or not is to have a comprehensive eye exam by either an optometrist or an ophthalmologist. By the way, going to your primary care physician, your general physician, and if they have you cover one eye, cover another, and they may even shine a light in your eye, that doesn't tell you whether you have glaucoma or macular degeneration or most any other eye disease. That doesn't count as an eye exam, nor does it count if you go to the DMV to renew your driver's license and you pass the eye test. That doesn't mean that you don't have any eye problems. It doesn't even mean that you have good or bad vision. So those are not substitutes for a comprehensive eye exam. In glaucoma, like so many other eye conditions, if you do happen to lose vision from glaucoma, it tends to start in the periphery, so off to the side before it affects the middle, which is the opposite of macular degeneration. But once you start losing vision, the vision that's been lost cannot be regained. And that's why it's so important to identify and treat early to prevent or slow down any vision loss, because once vision is lost, it cannot be regained. The goal switches to retaining whatever vision that you have. All right, so those are my 5 points on glaucoma. I've got a couple questions that came in. I'm going to see if any are glaucoma specific. So there's a question, does glaucoma affect my macular degeneration? And it in fact does not. So glaucoma and macular degeneration are completely independent of each other. The only way that they're really at all connected is if you are getting injections for wet macular degeneration. There's some thought that may over time cause an increase in your eye pressure that could potentially lead to glaucoma. But just having glaucoma or having macular degeneration, one certainly does not cause or alter the course of the other one. All right, so let's move on to cataracts. And this is probably one where I would expect a whole lot of questions. So I'm expecting to see the number by the Q&A bubble go up on this one, because this is something that is very, very common. So cataracts, everybody gets them as long as you live long enough. And so when my patients tell me they have a family history of cataracts, I generally say, congratulations, that's really good news. That means you have good genetics, because the only way you don't develop cataracts is if you don't get old enough to develop cataracts. So if in your 60s or 70s, then you have at least the beginnings of cataracts. Doesn't necessarily mean that you need surgery or need surgery yet, but you will have cataracts if you're in your 60s or 70s. Cataracts shouldn't be feared. So again, everybody gets them. And so it's not some terrible outcome or terrible thing that you develop and for which there's nothing that can be done. Cataract surgery can be done. And some of you, I would imagine, have already had cataract surgery. And most of you that have probably had really good results from cataract surgery. So it's certainly not something that needs to be feared, because cataract surgery for most people is pretty easy and not painful. One of the questions is, when do you know it's time to remove cataracts? So, there's not an absolute set answer, but the way that in our practice, at least, we talk to people about cataracts, so we just ask questions about their ability to function and whether their vision is at all affecting their ability to function or see things the way that they want to. It used to be that people thought your cataracts had to be ripe or they had to be really bad before you had surgery for it. And that really isn't the case. Because the surgery is so relatively easy and results are usually so good, there's no good reason to wait. As a matter of fact, cataract surgery a little bit earlier is generally easier for the surgeon with better results than if you wait too long. So it's not painful. It's pretty easy to go through. It's not something you need to wait for. Cataract surgery results can be as good or better than LASIK. So many people have heard about LASIK as a way to get rid of glasses. Well, the reality is when cataract surgery is done well, then most people are able to drive without glasses. A question that came in is, after cataract surgery, how long does it take for your vision to return? And what I would tell you is by the time you leave the surgery center, you should be seeing pretty well. And when you see the doctor the next morning after your cataract surgery, when I see patients the morning after one of my partners has done cataract surgery, most of them are seeing 20/20 the next morning. So seeing the smallest line on an eye chart without any glasses. Now, there was a comment that my friend has macular degeneration or cataracts removed, but her vision did not improve. How come? Well, that's because you cleared up the lens in the camera, but still weren't able to fix the film. So just because someone has cataract surgery doesn't mean that they will see better if they have something else going on, but at least that part of the cause of vision loss, cataracts, will be removed. Good questions. And then really importantly, cataract surgery does not make macular degeneration worse. For a period of time, there was some question around that, but there's been some clinical studies that have been done that pretty definitively show that if you have macular degeneration, it is completely safe, as from a vision perspective, from a macular degeneration perspective, to have cataract surgery done. There's not a good reason to wait. The longer you wait, like I said, you're just delaying the time until which you'll be able to see better and potentially making the surgery a little bit more difficult for the surgeon and or you. All right, so let me see if there's any other questions in regards to cataract surgery. If you come up with any more, please feel free to send those in. Somebody said my iris, that's the colored part of your eye, was damaged during cataract surgery. And since then, I have light sensitivity and wear sunglasses, even indoors as well as outdoors. Am I damaging my eyes by wearing sunglasses? I also have some changes to my macula. So no, you can't hurt your eyes by wearing sunglasses. I would encourage you, whatever makes your eyes feel comfortable. That's totally fine in virtually any situation. So wearing sunglasses, if you have light sensitivity, is a good thing. Wearing sunglasses to help protect your eyes in relation to macular degeneration can also be beneficial. So a comment that came in, 2 friends had cataract surgery the same day on June 30th. Both were told it takes 3 months to see a difference. True or false? The answer is false. Depending on the level of cataract, so the worse it is, you'll notice it as soon as you sit up. But really, people should be seeing well, relatively well, at least the next day. And oftentimes people wait a month or sometimes longer before they get new glasses if they need them. So what doctors will oftentimes say is it may take between 1 and 3 months for your eyes to completely heal after cataract surgery. Therefore, there could be tiny changes to your prescription, and therefore maybe don't want you to get glasses if you need them. For at least a month, maybe up to 3. But it certainly doesn't take 3 months to be able to see a difference. Good question. All right, so the next thing I'm going to move on to is diabetes. Actually, let me go back to one question. I had cataract surgery about 8 years ago. 2 days ago, I saw black specks like floaters and wondered if something happened to my lenses. So cataracts generally don't cause floaters. If you're seeing floaters in your vision, it has something to do with the gel inside your eye. Most of the time, it's no big deal, and it doesn't cause any real problems. However, occasionally, new onset of floaters could be symptoms of what's called a retinal detachment. And so if you have new floaters, then you should reach out to your eye care provider, and they should get you in within the next 24 to 48 hours to take a look. Because just like anything else, if you have the very beginnings of a retinal detachment or some other retina problem, you may see great when you do this. You can get the problem fixed and you'll continue to see great. But if you wait until you do this and you don't see well, then sometimes even after it's fixed, you may still not see well. So new floater is important to get your eyes checked right away. Does use of steroid drops after cataract surgery increase the chance of developing wet macular degeneration? There is zero research to say that. The only thing that steroids after cataract surgery or at any point could cause is an increase in eye pressure. But generally then when you stop the steroids, the eye pressure goes back to normal. So using steroid eye drops, whether it's from cataract surgery or something else, is generally not problematic and certainly should not be feared. All right, so let's talk for a few minutes about diabetes. This is probably the most important thing when talking about diabetes and eye care, is that good vision does not mean healthy eyes. I've had patients that when I look inside their eyes, it looks like a train wreck, but their vision's fantastic. And that's because it just hasn't yet affected the macula, the very central part of their vision. And so with diabetes, glaucoma, macular degeneration, anything else, you don't want to wait until your vision is lousy before you do something about it. Ideally, care starts before there's any effect to your vision to prevent any real change or loss of vision. So again, good vision does not mean healthy eyes. Good control of your diabetes does not completely prevent changes to your eyes, but it sure helps. Every study that's been done has shown that people that have better control of their blood glucose are less likely to develop eye changes or less likely to have bad eye changes than people that don't control their blood glucose. So as it turns out, everything's kind of connected, and what's good for your diabetes is good for your eyes. And almost anything that your eye doctor would tell you to do for your eyes, as it turns out, would be beneficial for your diabetes. So actually, we just had a question came in about glaucoma that I missed. If you have glaucoma, but not high pressure, what is the normal treatment? It's a good question, because if you have glaucoma, but your eye pressure is what for most people is normal, that means it's normal for most people, but not normal for you. And generally the treatment is still drops or laser or surgery to lower the eye pressure. So everybody's normal is a little bit different, where for most people an eye pressure of 18, for example, would be very normal. For some people, 18 causes them to have glaucoma and it needs to be lowered to 13 or whatever it may be with eye drops. So the treatment is still the same. Not all people with diabetes will have problems with their eyes. However, most at some point will have some degree of change. Now, that may or may not ever affect their vision. So just because you have diabetes related eye changes does not mean that you'll have changes to your vision, which again is another reason why routine eye care is so important, to catch those changes early and do something about them before they cause any loss or change to your vision. What's good for diabetes is also good for macular degeneration. So what I tell my patients with either of these two conditions, that there's 4 things they can do to try to improve the odds of having good outcomes, of not having problems. And the same 4 things work in both conditions. And those are: don't smoke, either don't become obese or try to lose a few pounds, try to get some exercise. And what I specifically tell people is you don't need to run marathons or pump iron, just do something. And try to have a diet with green leafy vegetables and less refined carbohydrates. So if you do those 4 things, you're helping yourself out in regards to diabetes. You're also helping yourself out in regards to macular degeneration. Treatment for diabetic eye disease, when needed, is very similar, if not the same, as it is for wet macular degeneration. So if someone has diabetes and require treatment for it because of a change to their eyes, then generally it will require injections, just like wet macular degeneration would. So a question came in: if you've lost vision due to diabetes and have to have injections, is the medication the same as used for macular degeneration? And yep, they're the exact same medications and generally used at the same intervals. So generally it's the same. Somebody said my last eye injection hurt. Why? So in general, people that get injections for either macular degeneration or diabetes would tell you that they really don't hurt. And that usually the biggest side effect, if anything, is it looks like their eye's bruised, like there's a red spot on their eye, or that they might see floaters for a couple days afterwards. But generally they don't hurt. Generally people feel just a little bit of pressure. And what I tell my patients is the worst part about getting an eye injection is when you hear about it for the first time and the anxiety that you feel at that point, but that the actual procedure is generally not really a big deal. So this person typed in, I was diagnosed with prediabetes in 2007, still at that stage, but I wonder if over the years, even prediabetes has detrimental effects. So far, I have low pressure glaucoma with some loss in one eye, very early signs of macular degeneration, just recently revealed after changing to a new ophthalmologist. So, it's interesting that if someone has pre-diabetes long enough, then the odds are at some point they'll actually develop diabetes. And it is possible to have changes to your eyes, even if you only have pre-diabetes. So, the most important thing would be, just like anybody else, doing your best to control the diabetes and trying to lead a healthy lifestyle with exercise, diet, appropriate weight status, and not smoking. So all those things really kind of come into play to help prevent diabetes, prevent changes from prediabetes, and prevent changes from macular degeneration. Are there any new treatments for diabetes in your eyes? So right now, really the only treatment are the same injections as for macular degeneration. There are some new compounds that are in clinical trials, most of which are actually injections still. But they're all pretty early stage. And so there doesn't appear to be anything on the horizon in the next year or 2 or 3 or probably even 5 in regards to something radically new or different for treatment of diabetes-related eye disease. Can you have diabetes and macular degeneration also? And so as it turns out, if somebody has diabetes, they're actually at a little bit higher risk of developing macular degeneration. So you certainly can have both. You can have one, you can certainly have either one without the other. Macular degeneration does nothing to increase your risk of having diabetes. However, diabetes does increase your risk to some degree of developing macular degeneration. When they use laser to treat diabetes, are they causing damage to the retina? It's a really good question because, in fact, the answer is yes. So usually if people are having laser to treat their diabetes in their eyes, it's a procedure where they have a whole bunch of laser spots applied. And each one of those laser spots actually kills off a very small area of the retina. And so it's complicated as to why that's the treatment and how it works. But you'll have to trust me that there are certain diabetes-related eye problems that require a bunch of laser to be used. And so it does damage the retina, but it's on purpose. And the idea is even if we damage the retina that's way off to the side, what that's doing is it's preserving what's in the middle. And so it keeps your central vision, even though it may have some effect to your peripheral vision. So that's actually a really good, a pretty insightful question. Have you ever heard of someone with diabetes, macular degeneration, and glaucoma at the same time? Yeah, absolutely. There are some people that get hit with all three of these. All three of these conditions, and needs to make sure that each one of them is handled appropriately. So for diabetes, the main thing is controlling your blood sugars. For the macular degeneration, oftentimes it's taking the right vitamins and making sure if it's dry to prevent it, try to prevent it from progressing to wet. And if it's wet, having that treated. And if you have glaucoma, to control the eye pressure. So, each one individually still needs to be addressed, whether you have just one or whether you have all three. All right, so let's move on to macular degeneration. This is the other one that I assumed that I would get a fair amount of questions for. All right, so Macular degeneration is age-related, but not all people get it. So some people live to 100 or beyond and never get macular degeneration. So just because you are of a certain age, it doesn't mean you will get macular degeneration. It just means you are more likely to. You are at greater risk. Question, what is dry macular degeneration and dry eye? So the two are completely separate. So dry macular degeneration is just kind of a stage or a classification of macular degeneration, and that affects the inside of the eye. Dry eyes affects the front surface of your eye. And generally, it's just as it sounds, your eyes get dry. And so oftentimes your eyes are a little bit red. Sometimes they could actually be teary, or they could feel dry or like there's something in it. So dry eye and dry macular degeneration are totally separate. Someone else just sent in, lately my eyes are runny, red, and very sore. Could this be an allergy? And yeah, it certainly could be. It could be dry eyes. It could be allergies. It's not likely an infection. If it's allergies, most of the time, but not always, most of the time, if someone has allergies that are bothering their eyes, they get itchy and they feel like they just want to rub at them. And as it turns out, there's some really good over-the-counter allergy eye drops, several of which that just recently became over-the-counter that before then were actually prescription strength or prescription. They're still prescription strength, but they just no longer require a prescription. So before I get more into macular degeneration, someone's asking a couple questions about a very specific type of macular condition. It says, my daughter's 20 and has Stargardt's dystrophy. Is this the same as macular degeneration? And will it progress to the point of needing injections? So Stargardt's dystrophy is something that's totally different from macular degeneration. It is something that is genetic based. And as it turns out, macular degeneration is mostly genetic based as well. But it is very different from age-related macular degeneration. Stargardt's never gets to where it needs injections just because of how it's different. It doesn't, people with Stargardt's don't develop abnormal blood vessels, which is what the treatment is for. Someone typed in, I've been seeing floaters and light flashes. Should I be concerned? So I don't know if necessarily you should be concerned, but what you should do is reach out to your eye care provider and get an appointment, because it is something that could be concerning, because it, like I mentioned earlier, it could be something called a retinal detachment that needs to be addressed pretty promptly. You definitely want to have it addressed before you notice any loss of vision. So question, what eye drops would you recommend for dry eyes? I think I've been waking up with dry eyes in the morning. So first step for most people that have dry eyes is trying an over-the-counter artificial tear. You don't need or want something that says it takes the red out. Redness is generally a symptom of something else underlying that's causing the redness. And what's important is to address the underlying cause, and then hopefully the redness will go away on its own. So you can go to the pharmacy and look for yourself. You can ask your eye care provider or even ask a pharmacist for a recommendation on an artificial tear. There are literally dozens, and most of them are just a little bit different from each other. And so your eye care provider may have one they specifically recommend, but if not, just trying something and seeing how it works. It's an artificial tear, but again, not something that says take the red out. All right, so let's move on with macular degeneration. Some people can have very good vision with macular degeneration, even if it's wet macular degeneration. And some people actually develop very poor vision, even with dry macular degeneration. So there's not a good kind or a bad kind. The good kind is the kind you catch early enough that you can act upon and hopefully prevent any real change or loss to vision. And so, as I just mentioned, there's not a good kind. It all must be taken seriously, whether it's dry AMD, wet AMD, early, intermediate, any stage needs to be taken seriously and addressed. And so asking your eye care provider for their recommendations as to what to do, but generally the only bad answer is nothing. Generally, there's at least something that you should be doing, whether it's diet, exercise, supplements, or something else. Like everything else, routine care is vital because macular degeneration, if it needs to be treated and it's caught early, then generally there doesn't have to be loss of vision. But the only way you'll know if you have a change that requires something done is with routine care. And so some people may see their eye doctor once a year. Sometimes an eye doctor may say, well, we'd like you to come 2 or 3 times a year because of something we see. And that's not unreasonable. What they're trying to do is if you have a change, to catch it early. If you're waiting until you have both eyes open and you notice your vision's changed to find a change from macular degeneration, it will be too late. You're waiting too long. So, it's really important to catch changes early. And that's actually something that we will hear a little bit about from Dr. Blemker when I'm done, about a really innovative in-home way to test your vision if you have what's called intermediate dry macular degeneration. As it turns out, it's something that I very regularly prescribe my patients as a way to monitor their vision. It's a way for really my office to be extended into their home, where they're using a digital device that's super easy to use to monitor vision on a very regular basis, so that if there is a change as related to macular degeneration, I'll get a notification, get the patient in right away. And if they need treatment, make sure they get it treated right away. So routine care, which sometimes involves digital testing in your home, is really vital to make sure that if there's a problem, that it's caught early. And then the last point I have on here about macular degeneration is AMD doesn't protect you from other eye issues. So we can't assume, well, I have this, therefore I can't or won't get that. It's completely possible to have more than one eye condition. And again, that's why routine care is so important. All right. So what I want to do next is answer more of the questions that have come in. And if you have more questions, feel free to send those in. There were a couple questions about a condition called retinitis pigmentosa. Again, it is not macular degeneration. It is something totally different. It's something that generally people develop when they're much younger, in their teens or 20s, that generally affects their peripheral vision. There are some vitamins that can be helpful, as it turns out, the same ones that are beneficial in macular degeneration. There is actually a gene-based therapy that is available for a very small subset of people with retinitis pigmentosa. So anybody with retinitis pigmentosa should probably have genetic testing done to see exactly where the change is, to see if they would qualify for the approved treatment. Are there any new treatments coming out for dry macular degeneration? So the one that has me kind of excited is there's something that's called photobiomodulation. And basically what it is, it's using a very specific wavelength of red light to change the way that the cells in your eyes work and to potentially reverse dry macular degeneration. So this is something that's already approved and being used in Europe, and is in trial right now here in the US. And actually the results have started to be released. And so that may be something that is able to be done as a treatment, where you look into a machine that shines a specific wavelength of light. I believe the treatment protocol is 3 times a week for 3 weeks as an initial treatment, and then some kind of booster treatments every 6 months. So it's not an injection, which is something pretty exciting. So that, to me, that's the thing that is the most exciting right now. Remember, there are vitamins that we know for certain stages of macular degeneration are helpful. So that's something else that I think is pretty cool. My dad has what is called end-stage macular degeneration. Is there anything coming that might return some of his lost vision? So, unfortunately, once vision is lost, it at least as of now, it cannot be regained. However, I think something that is oftentimes overlooked, and it's a shame, is something that's called low vision. And low vision, there's certain specialists that do what's called low vision. And that's taking people that have vision that's not correctable with glasses or contacts and trying to help them find different types of devices, whether they be magnifiers, standard ones that you think of, or things that are digital, to help them regain their functionality. And so even if there's not a drug to treat them or an injection or pill, there still may be other means to help them to be able to function, to be able to read or do the things that somebody wants to be able to do. So, probably the worst thing that a doctor could tell someone with macular degeneration or anything else is, sorry, there's nothing else that can be done unless they've already seen a low vision specialist. Someone typed in they're having increased difficulty adjusting from bright outdoors light, even with sunglasses. Is this normal aging? So if you're having a hard time adjusting from bright to dark, that's oftentimes the first symptom actually of macular degeneration, and generally gets worse as macular degeneration gets worse. The second part of that question is this normal aging? And what I tell people all the time is aging or age or birthdays is not an excuse for poor vision. If you've had more birthdays, if you're a little bit older, then that might just mean you're more at risk for age-related conditions. That doesn't mean you should lose vision or have vision problems. So, if your doctor says, well, you're not seeing very well because you are X number of years old, I would tell you that's not a very good answer, because the answer needs to be, well, because you have this condition that's related to your age that's causing you to not see as well. So age on its own never causes anybody to lose vision. Okay, so there's a question, are there any new treatments for myopic macular degeneration? So myopic macular degeneration can have some similar characteristics to age-related macular degeneration. As it turns out, the treatments are the same for myopic macular degeneration as they are for age-related macular degeneration. So myopic macular degeneration generally happens in people that are very, very nearsighted. And so they can, like I said, have some of the changes similar to people that have macular degeneration, and treatment, if needed, would be the same injections as somebody that has wet macular degeneration. So there's a question, what about gene therapy? So I'll answer that specifically as related to macular degeneration. And that's actually a really hot topic area for research right now in macular degeneration, using gene therapy. And so really what's being done is genes are being altered in a way and then put into a virus. And then that virus would then be implanted in the retina underneath the macula. And so basically then what happens is that virus causes the surrounding cells to be infected and to start acting as if they didn't have macular degeneration, start acting normally. And, before COVID-19, 3 years ago, this would sound like a great idea. But right now, if you talk about, using a virus and implanting a virus, that sounds kind of scary. But the reality is it is very, very controlled. And the early results from some of the studies are actually very, very promising. So it's not something that will be approved this year or next, but it's certainly something that's coming in the fairly near future to be able to use gene therapy, again, specifically for macular degeneration. Someone said, my glasses are very thick and now I have macular problems. Is this because of my eyesight? Well, so the way I'll answer that is going back to a few questions ago, the myopic macular degeneration. If you have very thick glasses because you're very nearsighted, that can cause some problems to your macula that are, as I said, are similar to macular degeneration that may or may not ultimately need treatment. So it's not the not seeing well that caused the macular changes. It was the changes to your eye that caused you not to see well, that it's kind of related. Those two are the same. A question that came in is, what is a macular pucker? And is it the same as macular degeneration? So macular pucker is actually something that's pretty common. And the analogy I would use, or the way to think of this, is think of the inside of your eye. Now think about what would happen if you laid a sheet of plastic wrap over it. Or if you want to go back to the camera analogy, what happens if on the film in the camera, you laid a sheet of plastic wrap over the film? What would happen? Well, what would probably happen is you would create some distortion to the image that you were able to capture with the film. And so a macular pucker is basically when you develop some extra tissue that's like that clear plastic wrap that goes over the macula and can cause it to become a little bit distorted and cause some changes to your vision. Sometimes it may require treatment. If it does, it's surgery. It's not injections. So it is very different in every way from macular degeneration. Looks like I have just two more questions, which is perfect timing. So let me address those two. If you do have any other questions, please send those in before I hand the presentation over. So one of the questions is, what is CMV retinitis and how is it treated? So CMV stands for cytomegalovirus. So it's a viral infection that causes changes to the retina. And so it is treated with antiviral medication. So very different than any of the conditions we've talked about, and is actually not very common. Macular degeneration, as Dusty mentioned, is extremely common. It is the number one cause of vision loss in people over age 50 in this country. So it is very, very common. CMV retinitis is very rare. And most eye doctors, if they see one or two people with this condition ever, that's a lot. So most eye doctors will never see a patient with that condition. Versus macular degeneration is something that we see on virtually a daily basis. Okay, so the last question that I have, unless somebody sends in another one. After receiving an injection in my eye for wet macular degeneration, my eyelid burned and got a little bit swollen. Why does this happen? So the actual injection does not go into or ever touch your eyelid. But sometimes if our eye gets a little bit irritated, it might cause some irritation to our eyelid and cause our eyelid to swell. So it was probably more your eye was a little bit irritated, and that then in turn caused a little bit of irritation to your eyelid. But the actual injections don't directly affect your eyelids at all. And quite frankly, most people, when they have eye injections, have virtually no side effects. All right, so I think I've made it through the questions. So what I want to do next is to hand over the presentation to my friend and colleague, Dr. Megan Blemker. Dr. Blemker did a residency after finishing school, worked in a private practice, and has worked for a number of different companies, and now works for a company called Notal Vision. And Notal Vision is a really innovative company for which she's the director of clinical affairs and education. And it's a really innovative company because of what you'll hear about from her in a potential solution they've come up with for how do you monitor your vision if you have dry macular degeneration. You know, if I've spent a bunch of time talking about catch it early, catch it early, catch it early, well, how do you do that? And so when I hand it over to Dr. Blemker, she's going to talk about how it is that you do that, how you catch it early, and how truly beneficial that can be for your patients. So, and again, before I do hand it over, I will say that I think I mentioned this earlier. This is something that I use in my patients all the time. And so it's something that, you know, I can tell you that I don't work for this company, for Notal Vision, and I do really believe in it. And I think it's a fantastic option for those patients that need it. So I want to hand the program over for a few minutes to Dr. Blemker to tell us a little bit about Notal Vision, what they do, and how they can potentially help you.
Thank you so much for the introduction. Notal Vision is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege. To reiterate some of the important points made in the presentation, I would like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered and prescribed by your eye care professional when appropriate level of vision and stage of AMD. It is a form of personalized medicine with the 4C Home device used at home in between your regular eye exams. It detects metamorphopsia or visual distortions in AMD. AMD, or age-related macular degeneration, is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic, meaning it does not resolve or go away, progressive, meaning that it tends to worsen over time, type of condition. And there are two types of AMD, dry and wet. Dry AMD is the slower changing, earlier form of the disease that puts you at risk for developing wet AMD. Wet AMD is the sudden change or advanced form of the disease. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In dry AMD, changes occur in the cells of the macula, and drusen, or deposits, build up in this area. These changes may induce blurry vision, such as difficulty seeing sharp details, both up close and from a distance. Dry AMD is the slow form of the disease with changes you may not even notice over time. Most importantly, dry AMD puts you at an increased risk of progressing to wet AMD. Over time, the size and number of these deposits can increase, which increases your risk of developing the more sight-threatening form, wet AMD. Again, dry AMD can suddenly change to wet AMD without any advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula. These blood vessels leak fluid and can sometimes bleed without any warning. You may not notice changes until significant vision loss has occurred. If you convert to wet AMD, significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion or straight lines that look wavy, and dark spots in the center of your vision or generalized blurry vision, as you see here on the screen. Unlike dry AMD, there are effective treatments for wet AMD, but these treatments are most effective when administered early on before symptoms are noticed and vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but they cannot restore vision that has already been lost. Once the wet disease starts, it will continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and before symptoms are noticed. But how early is early detection? Once symptoms of visual impairment are noticed, those wavy lines or dark spots appear, then vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision and your independence. So, wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps people with dry AMD detect wet AMD before you even notice that visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision, and this test takes just a few minutes per eye per day. Data from each test is sent to your eye doctor as well as the No-Tal Vision Monitoring Center, the medical provider of 4C Home. If a change in test scores is detected, the monitoring center alerts your doctor. Your doctor's office will then contact you directly to schedule a follow-up visit. The AMSR grid was developed in the 1940s and has long been recommended as a simple and accessible tool you can use from home to monitor for changes in your vision. However, by the time you notice vision distortions on the AMSR grid, significant vision loss may have already occurred. Fortunately, new technology, such as the 4C Home AMD monitoring program, has been developed to detect tiny changes before symptoms are noticed and reports them to your doctor so you can receive immediate examination and treatment. Testing with 4C Home is easy. You turn on the device and look into the viewfinder to begin testing. A bump will briefly appear and then disappear. Use the mouse provided to click where the bump appeared and return to the center dot. Data from each test is sent to the No-Tal Vision Monitoring Center for evaluation and then provided to your eye doctor. Regular at-home monitoring is like brushing your teeth. It's a good, healthy habit you do every day to help preserve your vision. 4C Home allows you to take a proactive approach to protecting your vision. A clinical partner will be with you every step of the way. After the No-Tal Vision Monitoring Center receives a referral form from your doctor, we will answer any questions, verify coverage, and ship your device. Once you receive the device, the No-Tal Vision Monitoring Center will walk you through setup and training. You and your doctor will continue to receive feedback from the No-Tal Vision Monitoring Center. Our team will be sure to verify your insurance benefits and discuss with you prior to your acceptance of the device and getting started with the program. There are low out-of-pocket costs for Medicare patients. Patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan will pay around $15 per month once their yearly Medicare fee-for-service Part B deductible is met. Your doctor will send our No-Tal Vision Monitoring Center the referral order for you to begin the 4C Home AMD monitoring program. Appropriate candidates have a particular stage of dry AMD and vision level, which are determined by your doctor. You will continue to test regularly at home. If a change takes place, your doctor will be alerted and have you come in for examination. In summary, the No-Tell Vision Monitoring Center works with your doctor to remotely monitor your dry AMD, helping you retain functional vision throughout your AMD journey. All right, first question is, my doctor doesn't have this in his office. This is the first time I'm hearing about this. They always give me the paper Amsler grid. How can I get this if my doctor isn't doing this? Excellent question. So the first thing I would do is I would suggest that you go back and speak with your doctor, let them know that you attended this program and you learned about 4C Home, and you'd like to know if you might be a good candidate for this. As I mentioned a bit ago, you have to have a certain stage of AMD, of dry AMD, and you have to have a certain level of vision. So your doctor would be able to determine that. And we did mention earlier the Macular Degeneration Association website. There is information about 4C Home on there, or you can go to our website, which is 4chome.com. I am happy to share that our team is growing for our company. So we have multiple representatives in different parts of the country now spreading the good word about our No-Tell Vision Monitoring Center and the services that we can offer to you. And we're actually coming up on some conferences as well. So Dr. Gerson and I and other physicians are regularly attending educational seminars, meetings, conferences to maintain our education, stay up to date on the latest and greatest information. And so we as a company support those meetings for optometry and ophthalmology, and we're able to share information about 4C Home that way. But definitely go back to your doctor first and see if you are a good candidate. Next question is, are there false positives? In short, yes. So any test or any device is designed to be sensitive. So there will be false positives and false negatives. So false positive meaning that there's an alarm, and essentially what's happening is that the system is detecting that there may be a change from where you started at baseline to where you are currently. So in our system, the artificial intelligence notices that this is a statistically significant event and will notify your doctor and bring you in for examination. So even if there is not that conversion to wet AMD, conversion from dry to wet, there are a lot of things that can happen in the macula. And so I know Dr. Gerson went through several of those conditions. And because 4C Home is a metamorphopsia detector, because it looks for changes in your vision, visual distortions, sometimes it can be very sensitive and pick up on other conditions. But at most, it's an inconvenience for you to go in for an extra visit, but it's always a good idea to be checked. And it just gives an opportunity to have your doctor check you out a little bit more frequently. Next question is, I have a little trouble with focusing my vision. Can I use this machine? So what we like to say for using 4C Home and being compatible with the technology is that you have to have that distance vision of 20/60, 60 or better, which, to give you a comparison, in most states, the level of functional vision or driving vision is about 20/40. So as long as you are corrected with glasses or you're corrected for distance vision, then you should be able to perform this test. Can I order this machine? So this is only available by a prescription from your eye doctor. And as Dr. Gerson mentioned, there are different kinds of eye doctors. I'm an optometrist like Dr. Gerson. Also, ophthalmologists and retina specialists can prescribe this as well, but it does require that referral from the doctor, again, to make sure that you're the appropriate candidate for 4C Home. Next question is, would you please review the cost and Medicare options? Absolutely. So we actually have an entire patient financial services team who would go over all of your insurance and benefits, what, if anything, that you might pay before you accept the technology, before you accept the program and want to move forward. And before we ship you the device, we'll make sure you have all the answers and set appropriate expectations for that. But generally speaking, if you have traditional Medicare, so red, white, and blue Medicare, then that's going to cover the 80% of this recurring payment every month. If you have a secondary or supplemental insurance that covers 4C Home, that additional 20% would be covered as well, and you would not have to pay anything. And this is for the majority of our patients. For a small percentage of our patients across the country, again, depending on your insurance plan, and that supplemental, you would have to pay an average copay of about $15 per month. But again, this is something we'd go over with you, make sure you're comfortable before you ever commit to the program, before we ship you the device. But if we have your information, we'll get our team on it to make sure we go through that.
Megan, I just wanted to make
Hey,
one.
Dr. Gerson.
Hello.
Yes.
I just want to make one comment on that question
Please.
is, and that I have quite a few patients using this. And when they come in, I oftentimes ask them, how much do you pay for your home monitoring? And they look at me and say, well, I've never gotten a bill. And so what I would tell you is the vast majority of my patients that are using it, or maybe are the lucky ones, but really are having zero out-of-pocket recurring expenses. And so what I tell people all the time is even if it costs $15 a month, it's a bargain. But at $0 a month, it's impossible to argue with that.
Absolutely. Thank you for sharing that. I'm glad to hear that your patients have had the same experience that we talk about, because as I mentioned, this is for the vast majority of folks. Like you said, it's kind of a no-brainer type of situation, that if it's covered and it's the latest and greatest, it gives you the best chance in addition to what your doctor's recommending for monitoring your AMD, then absolutely. If you fit the qualifications, then of course we recommend that you should be on it. So thank you for sharing that. The next question is, can you use this if one eye is dry and one eye is wet? Excellent question. In short, yes. And absolutely, this is a great idea for anyone who has converted to wet AMD in one eye, and we want to protect that fellow eye that's still dry, because that fellow eye that's still dry is actually at a higher risk of converting to wet AMD as well. So it's absolutely a good idea to be monitoring the dry eye. Now, if you've gone to converted to wet, then, and you had been using 4C Home, then that eye that's gone wet would no longer be a good candidate for this, because the technology is not trained to be monitoring you once you've gone wet. It's not indicated for that. But absolutely, if you want to protect that fellow eye, you should be on 4C Home. Can you use this if your hands shake? Another great question. Also, if you happen to have a tremor of any kind, it depends on the severity of the tremor, of the shaking, but because we don't have any kind of contract or obligation, I think the best way to determine if you would be able to use this and if you're compatible is just to move forward with the program. Let us send you the device. Our team will be with you every step of the way over the phone, talking to you about how to get started and how to successfully test with 4C Home. And then if for some reason that you're not compatible, then we would absolutely take the device back. So we'll cover the shipping to and from your home if this is something that you'd like to try. And of course, we think it's absolutely worth a try. If the machine finds a change, what does that mean? Should I be scared? So if there's a change that the machine has detected, this artificial intelligence has said, okay, this is where you started. This was the beginning of your testing, and here's where you are now. We think maybe something has changed. Then your physician will receive an alert and they'll call you to come into the office. So I don't think this warrants being scared. I think that this is a good sign that you're using the best technology available and that you have been given the best chance to catch something early. So if you have converted from dry to wet AMD, as Dr. Gerson mentioned in his presentation, any of these disease states in the body and specifically within the eyes, if we can get to it earlier, then you've got a better chance for good vision long term. And maybe in a moment, if Dr. Gerson is available again, he could share any patient stories that you may have had with 4C Home and how people have felt if your patients have come in after they've had an alert, or maybe what your process is if you get an alert from 4C Home.
Yeah, so if I have a patient with an alert, we try to get them in usually that day or the next day. And I would tell you that in general, the feeling for people that are using 4C Home is one of really more calming than anxiety, because they realize that every day they do the test is a day that they can be assured that they're not having a problem. And the way that I kind of set it up and the way that I know Notal sets it up with them is that if there is an alert and if you do need to be seen, that's actually good news. That's not bad news, because that means that you're potentially getting something taken care of before there's a problem. So even the, I guess, worst case scenario, if you're using 4C Home, is way better than most best case scenarios if you're not using it.
I love that you'd mentioned that it's more calming. I know that a lot of patients have told us that they really feel empowered whenever they're using 4C Home. They're taking charge of their disease. They are doing everything that they possibly can to get the best possible outcome. And like you said, detect that change early. So nice to hear that it's working out that way for your patients too. And then the last one here is actually a comment. It says, thank you. I was diagnosed with macular degeneration. My eye exam didn't show any leakage. My doctor suggested this machine. I had it 1 week and it picked it up early bleeding in my eye, 1 week, and it was treated and my vision is good. I don't want to give the machine back as it is my vision saver. So thank you so much for sharing your story. And this is absolutely why we do what we do, help save your vision. And I'm so glad you had successful outcome, early detection, and quick treatment with 4C Home. So thank you for sharing.
Impressive. That's great.
Yeah.
Well, Megan, thank you very much for sharing your story, No Tunnel Vision, what you do, because it really is a potential huge value to people that qualify for it. I really want to thank everyone that attended today's webinar. Remember, there's lots of other information available on our website, macularhope.org. As Megan mentioned, if you want to go to No Tunnel Vision's website, what's that website, Megan?
It's 4chome.com.
All right, so FORESEE home, HOME.com. So 4chome.com or macularhope.org are two great resources for further information. On the Macular Degeneration Association website, you'll see future programs. So we do have a couple more virtual programs remaining this year and some in-person programs. So depending on where you live, there may be an in-person program that's absolutely different than this available that you could attend as well. So again, thank you very much to our sponsors and thank you to all of you for attending. We appreciate it and hope to see you on the next one.